Welcome back. We are now moving on to session 2, and we are launching another report. We're making this a habit today. So our next report is an ILO report, which focuses on bridging social protection and occupational health to advance sustainable development goals. So of course, that topic was introduced very capably by Dr. Takala earlier, and all the presentations that started talking about occupational health and diseases and injuries at work as well. So we should have warmed you up to this topic. Now, the chair of this session is Xavier Couillet, who is sitting right next to me. He is the political advisor at the International Cooperation Unit at the Ministry of Labour and Employment in France. And we will hear from our colleague, Nathalie Both, who will present the findings of the report first, and then we shall have a discussion. We have some expert speakers who are joining us from France, Madame Magali Caillon. We have an expert speaker, Dr. Mirana Razamizon, who will be joining us from Madagascar, and hopefully also José Luis Correa Lopez, who is going to provide his contribution from Colombia, and our colleague, Marielle Fegourset, who is here with us today, but she will be also talking about her experiences in Asia and bringing examples from Asia. And the session will end with a roundtable discussion with Lou Tessier, Health Protection Specialist at the ILO, Ana Catalina Ramirez, the Specialist on Occupational Safety and Health, and Working Environment Branch of the ILO, and Ivan Ivanov, who is the Team Leader of the Global Occupational Health Program at WHO. So, without further ado, let me hand over to Xavier. Let me hand over to Nathalie first, of course. Oh, yes. Okay. So opening remarks to Monsieur Couillet, and then we will hear from Nathalie about the findings of the report. Xavier, over to you.
Merci beaucoup, Constanza, et bonjour à toutes et à tous. Je suis vraiment très heureux, et c'est vraiment le cas de le dire, d'être présent avec vous aujourd'hui. Je considère un peu que le BIT est ma deuxième maison. Alors, j'y ai travaillé il y a une vingtaine d'années. J'ai appris, en tout cas, j'ai développé le sens de travailler de manière intersectorielle, de manière très intégrée, et peut-être plus que dans mon administration d'origine, qui sont les grands ministères sociaux français. Et j'ai gardé cet esprit toujours de dépasser les frontières, et les travaux qui vont être présentés aujourd'hui illustrent à la perfection cette approche intégrée et intersectorielle. Mais il y a beaucoup de choses, comme par exemple aujourd'hui, je participe, en tout cas à des activités dans le cadre de l'accélérateur mondial pour la protection sociale et l'emploi, et j'avais le plaisir de voir le directeur de la protection sociale et le directeur de l'emploi chef du département de l'emploi du BIT à la même table, parlant sur des projets conjoints, et c'est très important. Notre session aujourd'hui vise à montrer l'importance de la coordination entre les services de santé au travail et la protection sociale pour améliorer l'équité en santé. Et je peux faire une petite confidence, lorsque nous avions préparé l'actuel programme de coopération entre la France et le BIT, nous avions identifié un certain nombre de priorités, et beaucoup de sujets sont prioritaires, mais pour donner du sens à une action, il faut quand même essayer de resserrer et de synthétiser les choses. Et donc, dans ce programme, on a mis sur la même ligne, on a fait le lien entre la santé, la sécurité au travail et la protection sociale. Et ce n'est pas si évident que ça. Intuitivement, on se dit oui, évidemment, il y a des choses en commun, mais concrètement, dans la vraie vie, j'allais dire, sur le terrain, comment est-ce que ça fonctionne? Et donc, il y a les points communs, la santé, la sécurité, le bien-être en général. Et j'entendais tout à l'heure les propos de notre collègue finlandais, très expérimenté, qui nous expliquait que tout ça, évidemment, est lié. Et que d'ailleurs, que ce travail s'exerce dans le secteur formel ou dans le cadre informel. Mais c'est quand même aussi deux sujets qui relèvent encore de domaines de politique sociale différentes, plutôt du côté de l'administration du travail, s'agissant de la santé, sécurité au travail, plutôt du côté des administrations chargées des affaires sociales pour la protection sociale, la santé, la prévention, la sécurité sociale. Et ici même, au BIT, ces sujets relèvent de deux départements, la protection sociale, SOCPRO et OSH. Et puis, il y a le rôle de l'OMS aussi, et c'est très important que la journée d'aujourd'hui se tienne sous l'égide des deux grandes agences onusienne en la matière, et Ivan Ivanov nous en parlera tout à l'heure, qui conduit un programme mondial pour la santé au travail. Alors oui, si ces spécialisations doivent être transcendées, les barrières, si elles existent, doivent être surmontées. Et avec l'équipe du BIT, je crois qu'on peut dire qu'on innove en soutenant sur 5 ans des actions visant à soutenir une approche intégrée. Alors aujourd'hui, c'est un grand jour car nous allons prendre connaissance des résultats de la recherche qui vont être officiellement publiés et Nathalie va nous en dévoiler dans un instant les grandes lignes. L'objectif principal, c'est de développer des modèles d'intervention intégrés que le BIT pourrait mettre en œuvre pour étendre la couverture au secteur informel. Et puis, bien sûr, il faut toujours être près du terrain. Je disais tout à l'heure de la vraie vie. Et les KPI sont essentiels et d'ailleurs, ils sont inclus dans la recherche. Et puis, dans un instant, nous prendrons ensuite connaissance d'expériences pratiques, d'expériences d'intégration et de coordination dans différentes régions du monde. Et nous verrons que si les objectifs sont les mêmes, les cheminements, parce que les histoires et les structurations sociales et l'économie des pays, les cheminements sont nécessairement différents. Donc, je voudrais insister à nouveau sur l'importance d'avoir uni les deux agences OMS, OIT pour l'ensemble de la journée, qui se connaissent bien et de longue date, mais qui renforcent toujours davantage les synergies. Et pour notre sujet dans cette session, c'est particulièrement important. Voilà, je ne voudrais pas être plus long dans ces propos introductifs et qu'on écoute parole aux experts et aux spécialistes.
Merci, Xavier. So we are moving back to English now for Nathalie's presentation of the report's findings.
Thank you very much, Cos. Thank you very much, Monsieur Cuillet. So today I will be presenting very, very briefly the findings of the research project that was jointly conducted by the ILO's Universal Social Protection Department and the ILO's Occupational Safety and Health and Working Environments branch. And the objective of the research was to identify the linkages that exist between occupational health services and social protection. So I'll start very quickly with just some definitions for those who may not know one of the subsystems. So social protection is the set of policies and programs that are designed to reduce and prevent poverty across the life cycle, and ILO conventions recognize 9 contingencies. Occupational health services are those services that have broadly a preventive function and are responsible for upholding and maintaining safe and healthy work environments. And ILO Convention number 161 identifies 11 functions for occupational health services. And we can see down at the bottom of the slide here, the conventions and recommendations relating to each. So what are the potential entry points for collaboration between occupational health services on the one hand and social protection on the other? So this slide tries to illustrate some of those entry points. So the first point is that occupational health services and social protection, in particular, employment injury insurance and social health protection, have a broadly common objective of upholding and maintaining health, whether within the workplace, in the case of occupational health services, or within and beyond the workplace, in the case of social health protection and employment injury insurance. They also have certain overlapping functions, particularly in relation to preventive services, curative care, rehabilitation, for example, within the international legal or social security standards and standards relating to occupational health services. And finally, there are also potential connection points in relation to the institutional architecture, because Convention 161 on Occupational Health Services identifies different modalities for the organization of occupational health services, and these include, amongst others, by social security institutions. So these are some of the connection points through which collaboration between the two can be identified. And so against this background, the research tried to identify or answer three broad questions. So the first is, what is the nature of linkages between occupational health services and social protection? And here in particular, looking at social health protection and employment injury insurance. In which countries are these linkages reported? Is it possible to elaborate a typology of linkages or coordination models? And so the research was comprised of a scoping review, which was conducted jointly with researchers from the University of Quebec, the University of Geneva, and University Laval in Quebec. And the scoping review identified broadly a paucity of literature, in particular in low and middle income countries. And so the research conducted 3 country case studies that themselves are based on desk reviews and key informant interviews. And these were conducted in Colombia, Madagascar, and Vietnam. So here I'll start very briefly with a very broad overarching findings of the research project in terms of the nature of and the kind of what was found in terms of the linkages between occupational health services and social protection. So the first finding is that there is a vast diversity in terms of the nature of linkages that exist between occupational health services and social protection. And secondly, that within each context, there are often multiple linkages that exist between the two. And in both cases, this is largely a result of the institutional fragmentation and the complex institutional arrangements of both occupational health services and social protection within contexts. Thirdly, in particular in the scoping review, it was often unclear which occupational health service functions were the subject of the linkage. So this was something that as well we were trying to correct for in the case studies. The final kind of general finding is that, as I mentioned earlier, while we expected to identify linkages between particularly social health protection and employment injury within the social protection system and occupational health services. Linkages are also found with other social security branches, including pensions and disability, for example. So now I'll move very quickly over to the types of linkages that were identified between occupational health services and social protection. So the first linkage is where the governance and legislative frameworks of occupational health services and social protection are integrated. And this was identified in Vietnam, for example. The second linkage is where one institution has a dual mandate, or the double mandate, of occupational health services and social protection. And so the mandate for the administration of these two subsystems within a single institution. This is the case in France in relation to the Mutualité Sociale et Agricole, and we're going to hear from them very shortly. But it's also the case in Colombia, and I'll come back to that. The fourth linkage is where social health protection or occupational health services perform some of the functions of social health protection. So in terms of the coverage and the delivery of health services. And this linkage was only identified in Madagascar. Fifth is where the administration of benefits for employment injury or disease are administered with other contingencies of the social protection system. And this can be the result of a design choice, as in the case of Vietnam, or not, as in the case of Taiwan, for example, and Colombia. The sixth linkage refers to the financial linkages. So here is where the social protection system, there are financial transfers between the social protection system and occupational health services. So this can be transfers from to employers to reimburse them for the services that they organize themselves for their workers, or it can be financial transfers to occupational health service institutions, as was identified in the case of Poland, for example. And the final linkage that was identified relates to referrals and information sharing between the occupational health services and social protection. This was a bit more rare, and it was identified relatively rarely, and this was mainly, for example, in Spain, in the context of an integrated program where collaboration was purposely the objective. So I will very quickly go over the case studies. So this slide just perhaps a little bit of background for each context. The main points that we want to make with this slide is to highlight the diversity of institutional architectures, both in relation to occupational health services and in relation to social protection systems. And this kind of highlights and illustrates the points that I was maybe making earlier about the diverse nature of linkages that exist, and the fact that there can be multiple linkages within context given this diversity. And so here is a very, very short recap of the actual nature of linkages that were identified in each context. So on the left-hand side here, we have a recap of the 7 linkages that I previously mentioned. And so I'll go quickly in terms of kind of a bit more information about each linkage in the different contexts. So for example, in Colombia, the first linkage is the integrated mandate of occupational health services and social protection within a single institution. In Colombia, it's the General System of Labor Risks, or SGRL, has a dual mandate, both for the prevention of occupational diseases and injuries, but also for the administration of employment injury insurance in particular. And the SGRL is administered by labor risk administrators who are responsible for the administration and implementation of the scheme. And this dual mandate presents certain advantages. For example, claim data from the employment injury insurance is used by some ARLs in the design of some of their prevention activities. The second linkage in Colombia is a linkage of an administrative nature. In Colombia, while it is the SGRL that covers benefits in the event of a work injury or occupational disease, these are to be accessed through the institutions that administer the social health protection system. And those institutions are then reimbursed, or the costs for the services are recovered by the SGRL if and once the injury or disease has been identified or confirmed as being occupational in nature. And so this is also, from this linkage also results the last linkage highlighted here, which is that there is an exchange of information between the 2 systems in relation to patients. This is largely for the purposes of reimbursement, however. But there is also a second linkage of this nature, which is that the social health protection system achieves much wider coverage than the employment injury insurance as administered by the SGRL and the ARLs. And so as a result of this, workers that may not be covered by the SGRL will nevertheless access medical services through the social health protection system, but the social health protection system will then not be reimbursed for those services. And so they deliver and then cover as well those services. But despite these linkages, there was limited reported coordination, particularly between the institutions that administer the occupational health services and employment injury on the one hand, and the institutions that administer social health protection on the other. So now moving quickly on to Madagascar, I'll start by the second linkage here. In Madagascar, social health protection is relatively fragmented, and it also achieves a relatively low coverage. There's only 5% of the population that is covered by social health protection mechanisms. And so in this context, and in partly as a result of this, the institutions that have a mandate, whose primary mandate is in relation to occupational health services, these are called the intercompany medical services, or SMIE, do engage in the delivery of health services that go beyond occupational health. And so these services include diagnostic services, for example, gynecological services, public health services. And these services are delivered not only to workers, but also members of their family. And so the role of these occupational health services in social health protection actually doubles the coverage of the population coverage of social health protection in the country, if we take their coverage into account. So they play a big role, a significant role in terms of extending coverage. This linkage also leads again to the last linkage, which is identified here, which is that within the SMIU, there is an exchange of information between occupational physicians and general physicians about patients. And this facilitates the effective monitoring and follow-up of health worker status, for example. Then there is a final linkage, which is not necessarily related to the other two. In Madagascar, the institution that is responsible for the administration of different social security contingencies, so this is the Caisse Nationale de Prévoyance Sociale, or CNAPS, is by decree mandated also to implement certain occupational health service functions. So these include, for example, prevention, awareness raising, monitoring of occupational health and diseases, and so on and so forth. In practice, however, the ILO research has identified that this role is broadly misunderstood by employers and is actually seen as relatively a duplication of the functions and the mandates of other institutions whose primary responsibility is occupational health services. I'll quickly go now to the case of Vietnam. We will come back to Vietnam in our discussion with Marielle, but I'll quickly highlight the three linkages that were identified here. So the first is that in Vietnam, provisions for the employment injury insurance are outlined in the law on occupational health services, whereas provisions for other contingencies of the social security system are outlined in the law on social insurance and the law on health insurance. And so this might indicate the desire of the legislator to legislate occupational health services and employment injury insurance in a coordinated or integrated fashion. And this is something that has also historically been identified in Paraguay, for example. In Vietnam, in Vietnam, it is also the case that workers who are affected by an employment injury or occupational disease, the medical services are accessed and covered by the National Health Insurance Fund, whereas survivorship benefits are covered by the survivorship scheme within the social protection system. And the employment injury insurance then covers cash benefits for permanent disability and rehabilitation, for example. And we'll come back to the implications of this design, this kind of institutional arrangement in our discussion with Maya. The final link in Vietnam is of a financial nature. The employment injury insurance scheme in Vietnam is mandated by law to allocate resources for the prevention of occupational diseases. And in this case, those resources, the manner in which this is organized or arranged is that employers who are affiliated to the work injury insurance can be reimbursed by the employment injury insurance, the services that they organize, the occupational health services that they organize for their workers. So it was very, very quickly overview of the findings of the research. Very, very quickly on the priorities for future research. Basically, the complexity of the literature of the linkages and the paucity of the literature made it very challenging to identify lessons learned and good practices. So instead, what we're highlighting here is priorities for future research. And so the first is to investigate the extent to which the existence of a linkage actually promotes coordination between social protection and occupational health. This is an open question from the research. We'll hear from the MSA in a minute where this is the case, where the integration promotes coordination. But it would be interesting to identify what facilitates coordination. The second element is the question as to the extent to which, when occupational health services are delivered by social protection schemes, this facilitates or ensures their comprehensiveness and their quality. And there were questions that were raised about this in the research as well. And Anna Katarina can maybe come back to this. And the last third element would be to research the implications, in particular, of the administration of work injury benefits by social protection schemes that are responsible for other contingencies. And I'll let Lou also perhaps speak on this later. So that was very, very quickly my presentation. I'll pass the floor back to Costanza. Here's the QR code to access the publication online. Thank you very much.
Excellent. Thank you very much, Nathalie. There's a lot of food for thought in this very interesting scoping review. And I'm sure, as Nathalie was hinting during the presentation, that we will come back to many of the issues that she has raised and that have emerged from the research. So I would like to call on our first speaker who was name-checked by Nathalie. We are delighted to have Madame Magali Caillon with us, who is the head of prevention at the Mutualité Sociale Agricole in France. And I will switch to French to speak to Madame Caillon, who is going to be presenting. Bonjour Madame, bienvenue et pardon pour l'attente. Mais on va commencer avec une question pour vous. Pourriez-vous nous faire une très brève introduction à la mutualité sociale agricole et en particulier de la manière dont elle a étendu la couverture aux travailleurs et exploitants agricoles depuis sa création en 1930? À vous la parole, Madame.
Bonjour, bonjour à tous. Je suis ravie d'être parmi vous aujourd'hui. Et alors, c'est en français, mais je vais présenter une première slide. J'espère que vous la voyez bien. Donc, qui va permettre de présenter la mutualité sociale agricole. C'est vrai que c'est un organisme, en fait, qui s'occupe de l'ensemble de la population agricole française. C'est une mission de service public avec une caisse centrale sur la région parisienne et 35 caisses qui couvrent tout le territoire rural, tout le territoire français. Et donc, c'est une gestion de la protection sociale au sens large qui couvre l'intégralité des domaines de la sécurité sociale. Donc, c'est aussi bien tout ce qui est les prestations maladie de la vie de tous les jours, mais les prestations aussi familiales, les prestations retraite, la couverture des accidents du travail et des maladies professionnelles et la prévention, et c'est dans ce domaine-là que je travaille, tout ce qui est l'action sanitaire et sociale, tout ce qui est le contrôle des cotisations et le recouvrement des cotisations sociales. Donc, c'est ce qu'on appelle un guichet unique sur le territoire français pour tout le monde agricole. Ce qui nous permet, dans l'approche que vous recherchez entre protection sociale et santé, sécurité au travail, d'avoir une approche systémique où on va s'appuyer sur les compétences en fait, de nos différents corps de métier pour prévenir en fait, des risques liés à la santé au sens large de la population agricole. La population qui est couverte, je dirais, en population active, évidemment qu'il y a aussi les retraités, les enfants, etc. Mais en France, il y a 1,2 million de travailleurs trimestriels moyens de salariés agricoles. Ça fait 700 000 équivalents temps plein dans environ 200 000 établissements employeurs. Ça marque aussi, il y a beaucoup, évidemment, comme dans le monde agricole, d'emplois saisonniers. Et puis, vous avez ce qu'on appelle les non-salariés agricoles. Donc, ce sont les chefs d'exploitation agricole ou les conjoints de chefs d'exploitation. Il y a environ plus de 500 000 exploitants agricoles. Et c'est de cette population-là que l'on s'occupe en matière de santé, sécurité au travail. Nos champs d'intervention sont très, très larges. Ça va de la production végétale à la production, évidemment, animale, mais aussi à l'agroalimentaire, en passant par les eaux, par exemple, ou l'ostréiculture, et même tout le secteur hippique, avec les champs de course et les centres équestres, et également tout ce qui est les organisations agricoles que peuvent être les banques dans le domaine agricole ou les assureurs dans le domaine agricole, donc du tertiaire. Donc, nos champs d'intervention en matière de santé, sécurité au travail et de protection sociale, donc, sont tous ces champs de l'activité agricole. Pour ce qui concerne la mission de santé, sécurité au travail à laquelle j'appartiens, eh bien, on est une direction au niveau national de 34 personnes avec des corps de métiers différents puisque nous sommes des médecins du travail, avec des infirmiers de santé au travail, mais également des conseillers nationaux en prévention qui sont soit des agronomes ou des ergonomes du travail ou des psychologues du travail, donc dans une équipe très multimétier déjà. Et nous animons dans les 35 MSA des équipes de santé au travail. Et là, je vous ai mis que sur l'ensemble du territoire, il y avait 218 médecins du travail et 237 infirmiers de santé au travail dans les 35 MSA, mais également les missions de prévention des risques professionnels avec 267 conseillers en prévention et des assistantes, évidemment, pour soutenir tous ces métiers, puisque le but, c'est évidemment de faire le suivi en santé au travail des populations agricoles, mais en même temps de développer toute une politique territoriale de santé et sécurité au travail. Nous sommes bien sûr la MSA sous tutelle des ministères de l'agriculture, mais aussi du travail et de la santé. Et nous avons un programme pluriannuel de santé et sécurité au travail avec 3 grandes orientations. Je vais pas détailler, mais ça montre toute la diversité des champs d'activité. Par exemple, sur le premier qui est préserver la santé dans l'activité de travail, on va s'occuper à la prévention des risques chimiques, la prévention des troubles musculo-squelettiques et des troubles psychosociaux, à la prévention des risques très importants liés à l'utilisation des matériels agricoles, des chutes de hauteur et tout ce qui est la question du maintien en emploi pour évidemment des actifs agricoles qui, comme le reste de la population française, vont devoir travailler de plus en plus longtemps. On a aussi évidemment des actions en fonction de l'enseignement agricole, en direction de l'enseignement agricole, et puis plusieurs études diverses et variées pour mieux comprendre en fait les expositions professionnelles. Sur le deuxième axe, on est sur l'accompagnement des projets et des transitions, et on sait tous que le monde agricole est énormément perturbé aujourd'hui par toutes les modifications climatiques, les attentes aussi environnementales et sociétales. Et du coup, on travaille aussi sur les nouvelles technologies avec tout ce qui est l'évolution des modes de production et l'utilisation des nouveaux matériels que peuvent être les robots, les cobots, l'intelligence artificielle et tout le développement de nouvelles technologies comme la méthanisation, le photovoltaïsme, mais aussi les modes de valorisation des produits en circuit court, l'idée étant toujours de faire le lien entre la santé et ces nouvelles activités de travail. Et pour le dernier axe, on est sur un champ que je vais plutôt développer là, sur la prévention du mal-être des professionnels agricoles, puisque dans ce champ-là, on mobilise les équipes SST, mais pas que. Vous allez voir des équipes d'action sanitaire et sociale, voire d'assurance maladie, pour pouvoir arriver à prévenir en fait les troubles psychosociaux des populations agricoles, sachant que nous avons un programme interministériel sur la prévention du mal-être agricole, puisque en moyenne, la population agricole est 20% plus soumise au risque suicidaire que le reste de la population active française. Donc, c'est un programme national d'envergure aujourd'hui qui est piloté aussi par nos ministères. Et comme vous m'aviez demandé de montrer un exemple, je vais m'appuyer sur cet exemple-là pour vous montrer l'approche systémique et pluridisciplinaire. Donc, sur la prévention du mal-être, il y a 4 grandes dimensions qui sont travaillées par nos corps de métier. C'est la prévention le plus en amont possible, c'est-à-dire comment on peut dévancer les problématiques de mal-être. C'est la détection, bien sûr, c'est l'accompagnement et l'orientation pour pouvoir évidemment éviter ce mal-être agricole. Et sachez que là, en fait, on finance ces programmes-là sur des fonds de prévention des risques professionnels, mais aussi sur des fonds d'action sanitaire et sociale, mais aussi sur des fonds de prévention en santé publique, puisque ça concerne les actifs, mais pas que, ça peut être les jeunes aussi et les retraités. Donc, très rapidement, on a différents dispositifs qui mobilisent nos corps de métier, mais qui mobilisent aussi plusieurs acteurs extérieurs à nos corps de métier. On a d'abord un module qui s'appelle « Et si on parlait travail », qui est un module de prévention primaire, qui permet, à partir d'un film qui a été réalisé avec des ergonomes, qui montre en fait la diversité et les problématiques qui mettent en discussion en fait sur les territoires ruraux avec des groupes d'agriculteurs, aussi bien les problèmes de transmission, les problèmes intergénérationnels, les problèmes de charge de travail, puisqu'un agriculteur, il va être aussi bien décideur, il va être organisateur du travail et c'est lui qui va faire le travail. Donc, il cumule toutes ces casquettes-là et quand il investit, souvent, il ne pense pas aux conséquences sur le travail, sur la charge de travail, sur sa santé physique et mentale. Et du coup, on essaye de mettre ça en discussion sur les territoires ruraux. On a aussi développé tout un réseau de sentinelles. Il y en a plus de 6000 aujourd'hui, vous voyez, au mois de juin 2024. 27% sont des salariés MSA, 17% des élus de la MSA. Je ne vous ai pas dit, mais c'est vrai qu'il y a autant d'élus MSA, 15 000 sur le territoire rural, il y a autant d'élus que de personnel de la MSA s'occupant de toute cette protection sociale, et puis de nombreux acteurs des coopératives agricoles ou du développement agricole qui sont devenus sentinelles. L'idée, c'est que ce soit des bénévoles que l'on forme pour être au contact direct avec le monde agricole et pouvoir détecter les personnes en situation de détresse ou de mal-être, entretenir un dialogue et les orienter vers des structures d'accompagnement. On a un numéro vert aussi qui est Agri-Écoute. Je vous ai mis aussi là les plus de 2000 appels en 2023. Ça peut être la famille qui appelle, ça peut être des voisins, ça peut être la personne directement. Ce sont des psychologues qui sont en ligne 24 heures sur 24, 7 jours sur 7 et qui permettent là aussi de garder un lien avec ces personnes qui vont mal, pouvoir leur proposer des rendez-vous avec des psychologues, jusqu'à 5 rendez-vous, et de pouvoir les orienter sur des cellules pluridisciplinaires de prévention du mal-être, puisqu'il y en a une dans chaque MSA. Et à 64%, ces cellules gérées par la MSA prennent en charge ces personnes qui ont appelé via ce numéro. On a aussi des cellules de prévention du mal-être, avec plus de 4000 signalements en 2023, 35 cellules, une dans chaque MSA. L'idée, c'est d'avoir en fait une cellule qui permet de travailler sur les personnes directement, leur situation en santé et sécurité au travail, avec l'action sanitaire et sociale et le contrôle médical. Et de plus en plus, on fait appel bien sûr aux équipes qui gèrent les cotisations pour voir comment on peut aussi distancer ou en tout cas prendre du recul par rapport au recouvrement des cotisations. Et on fait appel à des psychologues indépendants et des élus MSA pour animer, pour être présents dans ces cellules qui vont faire une étude approfondie au cas par cas de la situation des personnes. On a ce qu'on appelle une aide au répit. L'aide au répit, c'est on finance des jours de remplacement pour que des personnes qui ne sont pas parties depuis des années en vacances puissent partir avec leurs enfants, avoir accès aux loisirs. Et on prend en charge ces services de remplacement qui vont faire tourner l'exploitation pendant qu'ils vont se reposer. Et quand ils reviennent, on met en place ce qu'on appelle un accompagnement vers le mieux-être au travail en agriculture qui est expérimenté aujourd'hui, mais qui permet que la personne, l'exploitant, puisse revenir dans son exploitation et qu'on prenne du recul pour voir comment on peut mieux aménager son temps de travail, ses équipements. On fait appel aussi à des psychologues du travail pour pouvoir travailler avec lui pour qu'il ne se retrouve pas dans la même situation de mal-être quelques mois après. Donc ça vous montre en fait qu'on mobilise aussi bien en interne qu'avec des prestataires extérieurs différents métiers pour une approche la plus globale possible et systémique de prévention du mal-être. Et on le fait pour d'autres sujets qui sont le maintien en emploi ou la prévention d'autres risques. Ce programme mal-être, en fait, aujourd'hui, il est structuré avec des référents dans chaque MSA qui sont des coordinateurs, un agent de direction aussi qui porte, et l'idée, c'est de mutualiser au maximum nos pratiques. On a énormément évidemment de liens avec, parce qu'on ne fait rien tout seul, avec toutes les organisations qui maillent le territoire français, et bien sûr que derrière, il y a énormément de communication pour pouvoir aider au mieux en fait nos populations agricoles. Je vous remercie de votre attention et j'espère que je n'ai pas été trop longue.
Merci, madame. Non, c'était excellent. Merci pour votre présentation. C'était pas trop long, absolument pas. Et merci d'être resté avec nous. C'était un exemple vraiment effectif de couverture, d'intégration et d'approche globale, comme vous l'avez dit. Merci. Alors, on passe au prochain expert qui nous rejoint du Madagascar. C'est Dr Mirana Razamizon, qui est le chef du département technique de l'Association médicale interentreprise de Tananarive au Madagascar. Bonjour, Dr Razamizon.
Bonjour.
Bonjour, on vous écoute.
Bonjour
Et
à tous.
moi aussi.
Oui.
Bonjour.
Comment ça va? Oui.
Merci pour
Bonjour.
l'attente. Alors, docteur Razamizon, je passe à la première question.
Oui.
On sait qu'au Madagascar, l'Association médicale interentreprise de Tananarive, AMIT, est l'une des
Oui.
seuls services médicaux interentreprise qui offre une couverture aux travailleurs indépendants et aux professions
Oui.
libérales. Qu'est-ce que c'est qui a incité AMIT à étendre cette couverture? Et pouvez-vous donner quelques exemples des types d'activités et de sensibilisation que vous mettez en œuvre, s'il vous plaît?
Merci. Qu'est-ce qui a incité la mythe? Et ben voilà, il y a plusieurs choses. Premièrement, nous avons trouvé que les travailleurs indépendants et les professionnels, de professions libres ne sont pas couvertes par la protection sociale. Et c'est pour ça que nous avons pensé que il faut les sensibiliser à s'affilier à l'association, euh, moyennant cotisation, bien sûr. Et deuxièmement, il y a aussi la concurrence entre les services médicaux de travail. Donc, c'est la prise en charge de la catégorie de ces travailleurs nous différencie des autres services parce que nous proposons une offre plus ou moins complète et cela peut aussi nous être utile pour nos ressources financières. Et puis, quatrièmement, je pense aussi que cette affiliation aux travailleurs indépendants est notre contribution à la formalisation des travailleurs informels. Donc, c'est une étape dans la formalisation et cela peut faciliter notre partenariat avec les institutions publiques ou privées pour développer nos services. Et puis, deuxième question, quels sont les types d'activités de sensibilisation? Eh bien, nous faisons donc des séances d'information sur les avantages de la couverture sociale, quelles sont les différentes prestations offertes, qui sont les bénéficiaires. Et deuxièmement, dans cet exemple, nous faisons des séances de sensibilisation sur la prévention des risques biologiques, des risques de TMS, sur le port d'équipements de protection individuelle et aussi des éducations sur l'hygiène et des sensibilisations sur la vaccination. Et voilà peut-être pour les questions.
Merci beaucoup, Dr Razamizon. Euh, euh, je crois qu'on va perdre l'interprétation pour l'instant parce que nos collègues interprètes vont quitter jusqu'à 2 heures. Et alors, je crois qu'on va passer à la prochaine présentation. On va... Ah non, on a une deuxième question pour vous, brièvement. Alors, liée à la SST et des gestions de prestations de protection sociale, euh, est-ce qu'elles s'influencent mutuellement? Et pouvez-vous donner des exemples concrets, y compris d'initiatives conjointes, s'il vous plaît? Docteur, vous êtes
Oui,
encore...
oui,
Ouais?
oui, merci. Oui, ça marche. Oui, les activités de prévention et de gestion des prestations sont liées et peuvent se renforcer mutuellement. Ils sont complémentaires parce que la réalisation des évaluations de risque permet d'identifier les besoins en matière de prévention et proposer les prestations. Par exemple, euh, des actions de formation sur les bonnes pratiques en sécurité santé au travail pour une meilleure prévention des accidents de travail et des maladies professionnelles. Et un autre exemple, la mise en place de programmes de vaccination, de dépistage des maladies chroniques pour réduire les coûts liés aux maladies chroniques. Voilà.
Merci beaucoup, docteur, pour les exemples et votre breveté. Je vous remercie pour votre contribution en parlant de l'exemple du Madagascar. Merci beaucoup. Alors, maintenant, I will switch back to English, which I believe might have to be the lingua franca for the rest of the session. And we shall move on to our final speaker, who will briefly tell us about the case of Vietnam. So, Marielle, thank you so much for joining us. Marielle Fegursa is the project manager on social health protection for the ILO Decent Work for East Asia and the Pacific. So thank you for flying all the way from Bangkok to Geneva. We're delighted to have you here in presence, Marielle. And I just have one question for you. So, of course, Vietnam is one of the case study countries for the scoping review. So in Vietnam, medical care in the event of a work-related injury or disease is covered under the Health Insurance Fund, as we heard from Nathalie. So can you briefly highlight what the implications of this are?
Yes, thank you, Costanza, and good morning, everyone. So indeed, the decision to cover healthcare services in case of occupational diseases and illnesses under the health insurance scheme was a major policy decision for Vietnam. And it has a wide-ranging implication for both workers, but also the social protection system. So first implication is that it facilitates access to healthcare for all workers in the country when they face occupational diseases and illnesses. And why that? Because now through the coverage of the health insurance scheme, a large share of the population can actually access the services. So the health insurance schemes cover over 90% of the population, while the employment injury scheme only cover about 30% of the labor force. So it means that by this integration, it allows all workers to access healthcare services. And that's particularly important for workers in the informal economy that are typically left out from employment injury insurance benefits. So it results in a much more inclusive system that leaves fewer workers out of protection. A second possible implication that we have identified is on the financing perspective. Now that this approach consolidates healthcare coverage under a single fund, it streamlines processes that would have otherwise be duplicative. With this integration, actually, the country moved away from employer liability that pre-existed the current system, and that is also conducive, as you know, to a better protection and avoiding situation of lack of compliance when it comes to coverage of medical care for occupational services and diseases. It's also particularly efficient administratively. It means that workers do not have to prove that their need for healthcare is related to occupational diseases. They are automatically covered by the system, and that allows a quicker access to healthcare services and remove a lot of procedural barriers. If I may highlight two challenges we have identified with this system. One is on the financial sustainability. More evidence are needed on what the implication of this new system is. Why? Because the 2014 amendment to the health insurance law that integrated the two systems did not adjust the contribution rates. So that means that the system is still funded the same way, but without additional resources. So it doesn't mean that it's an issue currently, but actual analyses are needed to further inform whether adjustment on the financing mechanisms are needed or not. And additionally, while this integrated system complies with a number of international labor standards, we haven't identified two shortcomings. One is the application of waiting period. So it applies for the whole health insurance scheme. So that means including in case of occupational illnesses and diseases. So waiting period is an issue. And the second issue is the application of co-payment. For specific group of population and particularly for workers in the informal economy. So there are mechanisms to try to mitigate this co-payment, but the system is quite complex. It goes through employers' requests, it has ceilings. So this co-payment is an issue and potentially a barrier for good coverage.
Thank you so much, Marielle. So that was interesting. There's progress, but challenges still ahead. So very, very interesting case that we will continue to follow. So I think it is time now to move to the final segment of our session. And I will hand over to Xavier to lead the conversation with our experts. Over to you, Xavier.
Thank you very much. So now we are introducing a panel discussion with three distinguished speakers. So our colleagues here present at the table, Ivan Ivanov from WHO, Anna Catalina Ramirez, specialist occupational safety and health and working environment branch at the ILO, and Lou Tessier, health protection specialist, Universal Social Protection Department, ILO. And just to launch the discussion, I would like to ask one question the same to each of you, and you will answer consequently. The question would be based on the research we have heard beforehand. What are the main takeaways from the research in terms of how we work together internally within our institution and between the two agencies, ILO and WHO? So maybe we can first start with our colleague from the WHO, Ivan, if you can address the questions. Thank you.
Okay. Merci. Good morning, everybody. Thanks a lot to the ILO colleagues also for inviting us to contribute to this debate. I would start first at a very, very global level. In 2019 and 2030, there were two high-level meetings at the UN General Assembly on universal health coverage, where the heads of state and governments committed to a number of things to advance universal health coverage around the world. And among them is to scale up the global efforts for healthy and safe workplaces and to expand the coverage of workers with occupational health services. So that is one key. Second, if we move between us, as you asked the question, between us, we're currently cooking with the ILO, preparing a policy brief on enhancing health, safety, and well-being at work in a very comprehensive way that will cover also the aspects of health equity and health coverage of workers. And it is very important that workers do have health coverage, and that health coverage can also detect occupational diseases, can report them to the Social Security system, and can handle these cases. So that policy brief will be launched next year at the World Exposition in Osaka on the 17th of July as part of the Safety, Health, and Well-being Days devoted for the first time at the World Exhibition. There will be special days for safety, health, and well-being at work. And ILO is very much involved in many countries. Now, if we move to the national level, there is certainly a need for improving the collaboration between the ministries of health and the ministries of labor as being the holders of these two systems. On one hand, the health insurance and the social health protection, and on the other hand, the employment injury schemes for insurance against occupational diseases and injuries. So these two schemes, they need to work together, and they have to have very good relations in order to ensure that the medical costs for occupational diseases and injuries are somehow reimbursed to the health insurance on one hand, that the health systems, the health services, the primary health services, general practitioners and other primary health care services are able to detect and report occupational diseases. I recall a couple of years ago meeting the Ministry of Labor of Zanzibar, and I asked them, what are your expectations from the Ministry of Health? And they told me, well, we have a national law on the compensation of occupational diseases and injuries. We have a fund, but we have zero occupational diseases. Can they teach their doctors on how to report occupational diseases? Yes, this is the practical relations. Now, in terms of money, WHO has worked with the International Health Partnership, and we have included a module on workers' health in the One Health costing tool that allows countries to determine how much is the budget for healthcare, and that includes 3 interventions that can be delivered at primary care level that can be costed and eventually can be reimbursed. One is the visit of workplaces by a health provider to provide basic risk assessment and health education of workers. Then is the detection of occupational diseases, injuries, reporting, and follow-up. And the third is the medical surveillance of high-risk workers. And these interventions, they can be costed, and they have been attempts, for example, in Thailand, the health system asked the Social Security actually to come up with the reimbursement of these interventions that are delivered by their primary care. I don't think that they got too far, but that is possible. The major barriers for linking between the health protection and employment injury schemes on the one hand is the low reporting of occupational diseases. And paradoxically, it is, for example, a study in France shows that more occupational diseases are reported by the general practitioners, the generalists, rather than the occupational physicians. On the other hand, many of general practitioners in primary care, they're scared because the forms are so complex and sometimes written in a language that they cannot understand. So, these are the barriers that can be overcome by better collaboration between WHO, between social protection and systems at the national level. For example, in Tanzania, the Occupational Safety and Health Administration is training their general practitioners about occupational diseases to be reported and to be compensated, and encouraging them to actually report them. So that's my 5 cents to the debate. Thank you.
Thank you very much. What is your point of view, Anna Catalina, on the same question we share now?
Yeah, thank you, Xavier. Well, I think that both the research, but also the work we do from the OSH branch and the social protection department, has shown that the social health protection systems in particular have a great potential in terms of really supporting, covering that gap in terms of access to occupational health services. So Dr. Takala was talking about that gap, about 80% of the working population that has not any type of occupational health service. And what we have seen through the research and that talk to us, to WHO, to the ILO, and to our two departments, it's about how how social health protection systems can play an important role in organizing occupational health services in a way that we are covering informal workers, small and medium enterprises, self-employed, that are part of those populations that we know are most affected by this gap in terms of coverage. So I think the research shows some of the aspects that Ivan was mentioning in terms of, the how and the what and the how. So we saw that these systems, the social protection systems, can provide in certain cases provision of specific services, especially in terms of preventive and advisory services to workers and employers, but also in terms of rehabilitation was one of the main findings. But and that also sometimes these they can be financial linkages or financial relations to support such services and the provision of such services. It also shows us that when we talk about the how, sometimes this participation of a social health protection system is done through a legal background. In other cases, through basically institutional arrangements that are established and that actually are quite aligned with what the Convention 161 says in terms of, having a flexibility to organize occupational health services at the national level. So I think we have a huge opportunity in that sense when we talk about coordination and working together. When we talk about expanding social protection and social health protection, particularly to really have it, go hand to hand with expanding access to occupational health care, occupational health services, and that we definitely need to take that lift. And taking that lift implies not only going, I think in deep having deeper information on what are basically the financial arrangements that are needed and what are the type of also implications it has for both systems, but also strengthen this coordination that Ivan mentioned between health authorities and labor authorities, especially in aspects such as recording and notification of occupational diseases and injuries. And finally, I think that one other important aspect that we can, I take away from this research that also is interesting, at least from the OSH perspective, is that we normally, see or have I would say a little bit the tradition of seeing employment injury schemes more as the compensation part. No, we are sometimes very focused on the prevention, and let's say that these employment injury insurances are like, okay, we fail, so now we compensate. But basically, what we saw in the research, and we have I think other type of systematic cases, is that more and more employment injury institutions are also including preventative services among their menu of provisions to services to the different enterprises and workplaces. And that definitely, when we talk about transition to the formal economy, we need to consider expanding the coverage of these schemes. The gap is also overwhelming. I was looking at the data of the report. Around 63% of gap of of workers not covered by these schemes, and which decreased to 9% in low-income countries. So I think we have a huge challenge in that we also need to explore how to overcome together. Thank you.
Thank you very much. And finally, with Lou, from a social protection point of view, main challenges and solutions to expand the coverage and to include all aspects of the world of work, including diseases and accidents. What do you think, and what did you find in the? Did you find something new in the research, and how you will adapt the work of the ILO in this context?
Thank you very much. Very quickly, because I can see we're really out of time, and I really thank the audience for their patience. I'm not going to repeat what colleagues have already said. I think what we're seeing here, if I have maybe three main takeaways. The first is that it's imperative for social protection systems to collaborate with occupational safety and health systems, and more precisely with occupational health services, because it's an entry point towards investment in prevention. I think that we know, and Anna has mentioned it as well, but we know that historically social protection schemes have had a tendency, well, much like many health systems themselves, to focus on curative care and compensation. And while we know that actually prevention is both an essential component of preserving workers' health, but also ensuring the financial sustainability of social protection schemes themselves. We also see that there is a tremendous potential for collaboration across institutions responsible for occupational health services and social protection. It is illustrated by the many contact points, collaborations, and integrated interventions that's identified in the research. So I think that as the ILO, we need to adapt our intervention models and systematically be in a place of mapping out both systems and their complexity. I think here we can say for the for the anecdote that, for example, in Madagascar, we did an assessment of the social protection system, and then we realized that also Anna was doing an assessment of the occupational health services. And then interestingly, the WHO had just done an assessment of environmental health in Madagascar. So you see, that those, just so to say that we didn't pick those three countries like completely, randomly, but actually we had looked at what we had done. And so we can see there, and I think maybe we've already now starting implementing integrated approaches. We're doing this on the small scale in a value chain in Kenya through another project to see how together we can have an integrated implementation model across occupational health services and social protection extension. I think for us internally as the ILO, if we have one takeaway of this session, but possibly also of this event today, is that we need to acknowledge that we have a key role to play in addressing some of the social and environmental determinants of health. And we need to feel somehow empowered to do this across the house, even though we don't always resonate with health and well-being, but actually we do have an important role to play. So if this event can be somehow internally empowering, that's also good. Thank you for the WHO colleagues to have been here and support us in that process.
Thank you all panelists, very bright and very interesting ideas. I think Lou at last word, you wrapped it up, so I will not add anything. From a donor point of view, we are boasting that we have supported you during at least not during, but to launch the project. We are really very thankful to all of you for all the work done and for what is next to come, because implementing all these great ideas where you overcome barriers, you work together, you speak common languages. We need to do that. And that's our motto now, integrative approach. That's a key issue. Thank you. Thank you very much for panelists and all speakers.
And thank you to Xavier Coyer for chairing this session. Thank you to our speakers who intervened online, and thank you to everybody who is still in the room and who is also still online. We shall now go to our lunch break, and we will come back with the next session, which is very exciting because we will be talking about addressing informality within the health and care workforce. We have a stellar panel of speakers and also some great points, I am sure, that will be made to build on everything that was covered this morning, which was rather comprehensive. So thank you very much. And we shall see you again at 2 p.m. with interpretation.